Hi everyone. So just like Heather, this is also my first time doing a big talk like this, so don't judge me too much. Following Ralph through to wards, so I'm just going to talk a little bit about our wards as well. So what does a wards nurse do? As I'm sure you guys all do lots of stuff in your practice as well. We have dedicated wards nurses in each of our wards. So we have 2 dog wards, which are split into surgical and non-surgical. And then we have a separate cat ward as well on the other side of the hospital. And we also like to cater to each patient and their needs and try and do as much as we can for each patient in their own way. This factors into cat-friendly handling, also anxious and fearful handling as well, just to make sure that we're keeping hands off those patients that don't want us that too near to them, and also giving lots of TLC where we can as well. So at the Ralph, we use an online system called Instinct for our treatment sheets. So this is what it looks like. As I'm sure most of you guys probably still use paper variety in hospital. So the reason we like to use these is that it's also eco-friendly, but we can have everything in one place. So that means that if the clinicians want to update it from the other side of the hospital, they can, without losing sheets on the way, without treatments having to be missed, and that kind of thing. So another little bit of a snapshot, we can also add absolutely any treatment you can think of onto here, from your walks, your TPRs, to TLC, to eye loops, everything. So we have, when treatments are due, they come up in our yellow colour, as you can see. And then when they are overdue, unfortunately, they come up in red. But we like to leave those ones sometimes if they have gone for a procedure or something like that, so we know that we're not double dosing. Once they have been completed, they'll turn up grey, and then the green ones are the ones that are coming up. We can also add our alerts on there, so you probably can't see, it's quite small, but Ralph has his little blood transfusion note on there as well, and we can also add our allergies as well, like that. So back to Ralph. Ralph, a recap of him. So he is our 8-year-old male neutered golden retriever. He has been through quite a lot whilst he's been with us. So he has a heart murmur that we now know of. He is diabetic and he's had a splenectomy. As Becky just said, he will have recovered in ICU. And so before he comes through to us, all of his monitoring and everything will be tapered down a bit so that we can just carry him on through his days, make sure he's progressing nicely before he can go home. So when he's coming over towards, we need to think about setting up his kennel. Obviously, quite obviously, you'd think he'd go into a walking kennel, which is exactly what we're going to do. We're going to set up a nice big kennel, give him lots of space to make it all comfy. Obviously, when we have other patients in, we'll think about their specific needs and size as to where and when they'll go in the hospital. We like to give all of our patients mattresses, and obviously thinking of Ralph, we know he's 8 years old, so we're going to start thinking about that joint support, make sure he's got a mattress in there as well. Of course, if they start to rip it up, then unfortunately they lose their privilege. Inco pads, we'll always put Inco pads down, and vet beds as well, just to make sure it's nice and comfy to help drain away any moisture that's leaking, if they happen to have a wee in their bed. However, if Ralph, for example, if he was entire, we might not even use a vet bed because we found that it irritates their testes quite a lot. So we have just blankets in there for him, and we'll like to make it as homely as possible using pillows and blankets, and you'll often find lots of pictures of them all tucked up in blankets. It's really sweet. And then our teddies. So special mention to our teddies. We like to keep everything as anxious and fear-free as possible. So we'll use a dog-appeasing pheromone or something like that and spray them onto our teddies, and just to give them a little something to cuddle up to as well. Sometimes we've got bandanas as well, which we'll place on the particularly anxious ones that we know are coming in before they make it into wards as well. So TPRs and observations, I feel like we've talked a lot about these already today. I know the ICU touched on them. Ours are still important though, because we can look at them and see if they are trending downwards, and we need to look at maybe Ralph going back to ICU or anything like that. So temperature, one of the main things is we're looking at, is he becoming pyrexic at all? And then that gives us chance as nurses to troubleshoot a little bit. So is it because he's systemically hot? Is he becoming pyrexic and he needs to, is he deteriorating? Or is he environmentally hot? Is he stressing? That kind of thing. And then we can start to think about putting our fans and things like that on him. Pulse, obviously, earlier we knew it was quite high, so now we just want to make sure it's staying steady between 60 to 120 beats per minute. We also know that this can elevate with pain and stress as well, so this is something to think about. His respiration rate, so normally a dog is 10 to 30 breaths per minute. That's what we're looking for. But also with Ralph, we know he has a heart murmur, so we need to make sure that we're looking at the effort as well, not just the rate. So the rate might be normal, but his effort has really increased, and then that could be indicative of fluid overload. And then, of course, his mucous membranes, this is important as well to keep an eye on, because we know that he had a low PCV pre-surgery. We know that he's had a transfusion, so we need to be making sure that they are nice and pink and moist as well. And then mentation, we check all of our patients for mentation, but for Ralph it might be a little bit more, you're thinking of his glucose side as well. So mentation, is he sad? Is he depressed? Could this mean he's deteriorating again? Does he just need a little bit of stimulation? That sort of thing. And then, like I said, linking it to blood glucose, has he become hypoglycemic or is he hyperglycemic? So other observations, we do our fluid checks. So like I said, he has a heart murmur, and we're looking at the rate and effort of his breathing. For his fluid checks, we're looking at the fluid bag, making sure he's on the prescribed fluids, and also that the rate isn't too high. For him, it might be less than any other patient, again taking into consideration his heart murmur, and also any other medications and fluids we double check in wards as well, just so that we're not accidentally giving the wrong drug, or it triggers us to think, oh hang on, that's a little bit much, or that wasn't quite what I wanted. So once a day, every 24 hours, we'll also look at his IV maintenance. Again, I'm sure this is something you guys will do in your vets, but we're stripping it right down to the tape, and we're looking to see if there's any signs of phlebitis, redness or swelling around the IV, and if there is, then we may be thinking about having to remove that. We're also flushing it before we redress it, just to make sure that it is still patent. Again, if there are any issues, it might be a case of removing. Oh, I didn't realise it actually went over, but the bottom one does say eye lubrication. So whilst they're on analgesia, we will do lubrication at the same time, so every 4 hours. And then once they are weaned off of analgesia, it could be up to every 6 hours. Just because he is in hospital, there is still ventilation going on, it will still dry his eyes out. So our holistic care, as we know, he's diabetic, and as Heather said earlier, that he'd probably be polyuric and polydipsic, so we need to make sure he has adequate walks and access to water bowls throughout the day. And feeding wise, also as Heather said, suitable diabetic diet will be fed to him to coincide with his insulin dosages as well. For other patients in the wards, we feed up to 4 times a day. If they don't have any other needs, it means that they can't be fed that often. So looking at him as a whole, we, like I said earlier about mentation as well, is he a little bit sad, does he need stimulation? So our TLC doesn't just include cuddling and warming up to them, it's taking them outside, maybe sitting out on the grass for a little bit, playing the radio, even sometimes playing a video and getting them to watch TV, and that has actually settled quite a few patients in the past, which is quite nice. Once they've had some TLC like this, we'll get some videos and some pictures, and we send them on to our patient carer liaisons, and they will then send it on to their carers as well and give them a non-clinical update, which I think carers really like. They like the interaction. They can see their own pets stay throughout the hospital, which is quite nice. So thinking about surgical care as well, as we know he's had a splenectomy, he's going to have a huge wound as well. So we need to make sure that that wound is kept nice and clean. So from his procedure, he will have a Primapore placed straight away before he goes back to his bed and recovery in ICU. And we like to keep that in place as long as we can, as long as there's no issues with it. We also need to make sure that there is no patient interference or environmental interference as well. So if it's flapping in the wind or they've managed to pull it off, we'll have to take it off and replace it. And also then it gives us a good chance to look at the wound to make sure that it is healing okay, that it hasn't got red or starts to discharge or anything like that. So patient interference, you'll probably have this everywhere has buster collars, I know, but there's buster collars, cloud collars, and then as Ralph is modelling, a nice pet t-shirt that we want to make sure is nice and snug so he can't get his nose in anywhere. Yeah. And also for surgical care, we're thinking about pain scores, because the reason he might be trying to interfere with his wound is he actually painful? So I think there was a question earlier about pain scores. Obviously, if he's really not letting us touch him, we won't push it too far, but we like to pain score them just before they're given their next dose of analgesia, as that gives us the most accurate representation of how he's feeling and how painful he is. And also, if it's not as painful as we expected, then maybe we can taper this analgesia down. Maybe we can change the analgesia or stop it altogether. So I'm actually going to talk about some NG/NO tubes. So also in wards, there is quite a chance for us to be able to place urinary catheters to maintain them, to maintain drains as well, we often quite get from surgeries, and also we get to maintain nasoesophageal and nasogastric tubes. So whilst Ralph was recovering in ICU, it was seen that he wasn't eating very well, so we decided to place an NO tube. So considerations for him, most times for an NO tube or an NG tube, you can place them consciously, so we're not having to put him under another sedation just to get it into him. And they're usually quite well tolerated once they are in place as well. They're quite low maintenance as long as all the checks and everything are done quite well, and they're suitable for bolus or trickle feeding, which is what we're looking for to do with Ralph, just so that he has enough nutrients for his insulin to be delivered as well. However, they are a bit of a pain sometimes. They can be quite a narrow bore tube, which means if the diet we want to use has to be mixed up and blended down, it becomes quite hard to get it to the right thickness for it to feed through. Also, we cannot be administering any oral medications through the tube, especially your tablet ones that have to be crushed and again watered down, because otherwise we're going to get blockages there. And also, they're quite irritating, so they can be sneezed out every now and then. If we notice that they're getting a bit irritated and starting to sneeze, we can use a little bit of proximethicane just to put down the nose to numb the area, and most of the time that stops them from carrying on. So, talking about placement. So we need to make sure we've got all of our equipment ready to go. So we need a tube, of course, the right size that will fit nicely for him. We need our suture material to secure it into place. We need our syringes so that we can check afterwards that we are in the right place. And then I've got needles again for suturing. We've got our proximethicane to place into the nostril again to numb it beforehand. And every now and then we might need a light sedation, so it's always good to get those doses ready to go before you start. So as I said, you want to have the right tube. We need to measure that as well, so it's the correct length. So for an NO tube, we are measuring from the nostril to the 8th to the 10th rib, and for an NG tube, we are measuring from the nostril to the 13th or the last rib. And when we've got that measurement, we'll put a little mark on the tube just so we know how far we need to be advancing. We're also going to check for stickiness of the tube as well. So the tube will have a stylet in it. We will take that stylet out, place some saline into the tube so that later on there won't be any damage when removing the stylet. So the stylet will go back in once the saline's in. And then we just need to make sure we are positioning our patient correctly. So they have to be sternal, they can be sitting or standing, and with their head slightly tilted back, just so we can visualize the area really nicely. So once that's done, we'll also be putting the proximethicane into their nostrils. And you can also ask someone else, your assistant or whoever, to do that as well whilst you're getting all your bits ready. So now he's in the right position, we're going to lubricate the end of the tube. This will help aid the insertion, make it nice and smooth. And we're going to go in with a ventral aim, just to go in, and it should go in quite smoothly straight away. If it doesn't, then you'll probably have to come out and try and re-aim it again. And then you want to just carry on feeding it through in short dart-like movements. And as it advances, we're going to be monitoring for signs. So we're going to see if he has swallowed. This will indicate that it's gone past the pharynx, and then as it will continue, we'll see check for any signs of gagging, which could indicate that maybe it's gone into the airway instead of carrying on down the esophagus. So how do we check that a tube is in place? Like I said, we'll get our syringes and we will check them. Once the stylet is removed, we will attach our syringe onto it, and then we will be drawing back. We want to either have our negative pressure if it's an NO tube, or our gastric fluid if it's an NG tube. If we have neither of those and we're just getting no resistance and lots of air coming back, I think we can safely assume it's in an airway, and then that tube needs to be removed straight away. So we have a picture here that it's actually coiled in the pharynx in the first picture, and in the second picture it's actually pointing up into an airway. Both of these obviously are not ideal, so we'll want to remove those and again retry. And then our last picture is nicely in the stomach or the esophagus for us. So once it's in place and we're happy with that, going back to it. Obviously, we'll always check with a lateral view x-ray as well. Although we can say that we have negative pressure, it could be that it is coiled and then it's not actually in the right place, which is why we check with an x-ray after to make sure it definitely is. So once it's in place, we will secure it. We'll use 2 finger trap sutures. We'll do one by the nostril, and then we'll do one by the zygomatic arch. The one by the nostril, obviously we want to make sure we're not getting those whiskers involved, keeping it away from sensitive areas. And then the one by the zygomatic arch is going to be a little bit looser, so it's not pinching at the skin or causing any irritation that might make Ralph want to flick it out. And then, as he's probably already wearing, we're going to put a buster collar on him just to stop that extra scratching or flicking it out. So obviously he's had to have some food administered via the tube whilst he's been with us. So although we've just talked about checking the tube placement, before we administer any food, we're going to check that tube placement again, just to make sure it hasn't moved and displaced into anywhere where we don't want food going. So we can aspirate that tube. Again, we're looking for that negative pressure or gastric fluid. And then we can also flush 3 to 10 mils of warm sterile saline into the tube, looking for any signs of coughing or retching. And then once we're happy it's in place, we can get his food, which will already be prepared and warmed up enough for him to have administered, and we'll feed it quite slowly over 30 minutes. Now here at the Ralph, we're quite lucky we have syringe drivers, so we'll be using a syringe driver to feed it at the allocated time that we've set it to. However, I'm aware not everyone has them in practice, so you'll probably be doing it manually. And then at that point, you'll be doing it probably about 1 ml a minute, just to make sure it's at a nice steady rate. And then once he's had the food, we will flush that tube through, just so that we're not leaving any food in there that can either cause a build-up of bacteria or a blockage for the next time. So I feel like I rushed through this. So an end in sight to his recovery. So just to finish Ralph off through his stay, so we supported him daily and done everything that we can, part of TLC, his feeding. So he's actually started to feel a lot better. He's eating by himself now. Really nicely, which means that we can then tailor his meds down, and we can put them onto oral meds, make it easier for him to take when he goes home. And then this also means that we'll start to be able to remove his lines, like his feeding tube and like his IV line, once he's had a discharge booked. And then last things last is just to make sure he's all ready to go home. That he's nice and presentable. So we will have groomed him throughout his stay anyway, but just give him one last groom, make sure he's looking happy, bright and ready to go.